Hi, this is Dr. Nick. I'm Principal at ECG Management Consulting, and welcome to the Health Tech Net session for Friday, April the 29th. We are looking forward to discussing the virtual nursing program, but before we get into that, Jim, would you like to give us a quick introduction to Health Tech Net and bring us up to speed?
Certainly. Hello, everyone, and welcome. We're delighted to have everybody here today, and we are grateful for everybody's adaptability and flexibility as we pivoted at the last minute from a hybrid meeting to an all virtual meeting. So I hope and trust we haven't left anybody dangling at the last minute or left anybody standing outside the meeting room at George Mason University wondering where everybody is. So I hope we've been able to handle that well. Let me just preview the next meeting very briefly. Dr. Joe Bormel is going to be the presenter and orchestrator of that meeting around the topic of adapting commercial workflow technology to healthcare. That meeting will be on May 20th, Friday, and we will be back. We'll be back in our usual rhythm of the third Friday and back in our most normal place, which is, not that this is an abnormal place, but we'll be back at the Nelson Mullins office in downtown District of Columbia. So looking forward to seeing you all there. David Main, do you want to add anything before we turn it back to Nick and start the program?
Just very quickly, yes, thank you, Jim. We will be back in our normal meeting space, which has been renovated to some degree, but we'll be back in the Rotunda room. I'll just add that Jim and I have been talking offline about the uncertainty of meetings these days. I don't know if in your line of work what you're seeing, but just even in terms of large events or even small business events, there's a certain amount of confusion, I think, in people's minds and schedules about whether to do things in person or whether to do things virtually or to try to do some combination of those two. And I think some of that's related to COVID, some of it's related to just people's habits changing so that they would rather do things online. At the same time, I think people really do treasure the opportunity to meet in person. So that's combined with the usual confusion in the month of May, late April and early May, about spring breaks and graduations and weddings and all sorts of things that are causing people to travel or to be unavailable. So we'll keep plugging away and doing the best we can, and we're hoping for an uptick in normality or normalcy, whatever the right word is, as we get back into the summer. And unfortunately, Dr. Fauci has assured us that the pandemic is no more, which is nice. I wish we could say that about the economy improving, but that remains to be seen. So thank you, Nick and Jim, for organizing this, and Joe for organizing the next one. We'll look forward to it.
Okay. Well, thanks for that. Appreciate everybody participating and joining us online. It's my pleasure to introduce two colleagues and friends I work with, both brilliant minds, brilliant implementers, and in part thanks to some early work by Sandy, who will share her own background, which I think is highly relevant to this, and driven by the pandemic and the shortage of nursing, rethinking the way that we approach the resources with a virtual nursing approach to sort of resolving this resource issue. So I'm going to hand over to my two colleagues and thank them for joining us today.
Great, thanks. And Nick, do you want to pull up the deck? We'll share that. And thanks everybody for having us. We're excited to present to this group this afternoon. It's really an interesting time in healthcare and healthcare delivery, and so really thinking differently about how we deliver healthcare is something that we're passionate about. I'm Sandy Meyerson. I'm an associate principal at ECG, and I'm part of our hospital performance improvement leadership team under the Performance Transformation Division. I'm a registered nurse. I have a clinical background in ER, critical care, trauma, and flight nursing, and worked clinically for a very long time until I moved into performance improvement, and then leadership roles and executive leadership roles before I joined ECG. I've been a chief nursing officer for a system in Philadelphia. And then I went into consulting for a little while, really focused on optimizing patient experience and patient flow. Then left consulting to become the inaugural chief patient experience officer for the Mount Sinai Health System in Manhattan. And then left there and joined ECG about 3 years ago. And my practice at ECG is really around workforce optimization, capacity management, patient experience optimization, and really ensuring that we're providing the best care possible and using our resources as optimally as possible. So looking forward to today's conversation. Owner?
Thanks, Sandy. Good afternoon, everyone. It's Owner Torsholu. I am a recent addition. I guess maybe I can't use that term anymore. Almost a year in with ECG now. My background is similar in the sense that I spent my last 20 some years in healthcare space, both in provider, payer, and supply chain side of the puzzle. Most recently, I was the Chief Digital and Analytics Officer with St. Luke's Health System out of Boise, Idaho. Prior to that, Chief Data and Analytics Officer with Ochsner Health System. I have served as a technology leader with Cleveland Clinic, Cardinal Health, Humana, rounds up most of my experience over the last 23 years or so. I'm looking forward to the conversation today as well.
That's great. So let's walk through our agenda for today. Really, what we want to do is make sure that this group knows who ECG is and what we do, and then spend the bulk of our time today talking about really why are we in the situation that we're in today, and how do we think we can integrate virtual technology into the inpatient care delivery side of the house. So just a little bit about ECG. We really have, all we do is healthcare management consulting, and you may know this from your work with Dr. Nick. So we do work in strategy and finance, operations and technology, but it's entirely our focus is healthcare. And I have just been delighted to be able to work with ECG because we have such smart people in the healthcare space. And so if there's a need that we identify with a client where we can help them in an area that I'm not currently helping them in, I know that there's someone across the firm that I can reach out to who can help with other areas, whether it's technology or FMV arrangements or managed care products. And so we just have a lot of really smart, talented people across ECG focused on helping our clients improve healthcare delivery. So let's talk about why we're here today. As you may be aware, we have a significant shortage of both RNs and LPNs, and by more than 1 million nurses. So there's a gap of 1 million nurses that we will need to fill by 2030. And that's going to be a difficult task to achieve, even if we had all of the opportunities for nurses to get into the field. Part of the challenge, as you know, is we have an aging population. Baby boomers are retiring and living longer, and diseases that used to end in a terminal way are now really considered chronic because of advances in medical science and technology. So we have a bigger population that's living longer and are requiring additional healthcare resources. And with that, think about Medicare. Medicare is trying to pay for all of this. And so Medicare is driving how they're reimbursing organizations for healthcare services and pushing a lot of the care outside to the ambulatory setting. So if we think about the direction in which hospitals are going in particular, the patients that end up in hospitals are those that have multiple chronic conditions or very acutely ill who require a lot of nursing care as well as medical care. In addition to that, we have nurses who are also reaching the retirement age. And what happened at the start of the pandemic is nurses who were close to the retirement age or at retirement age said, I don't really need this added stress in my life. I don't want to put myself at risk, and I'm going to retire. And so lots of nurses retired or were laid off at the start of the pandemic, and that trend has really continued. And so we've lost not only a lot of nurses, but we've lost a lot of experienced nurses from the bedside. The other contributing factor is that, as you know, most nurses are women. And because of the fact that they are, nurses often work few hours because they're raising a family, or they leave the profession altogether, or they take a leave of absence to raise their families, has implications on the availability of nurses to care for our patients. And then the last piece is really that, well, there's certainly an increase of people going into the nursing field, both men and women. There is a limit to the number of nurses we can train annually. We're limited by the number of the faculty that are available to teach nurses. We don't typically reimburse nursing faculty well. And so unless you're really passionate about teaching, it may not be something that you want to do. And there also is a limit to the number of locations where student nurses can go for their clinical rotations. And so working with hospitals and across the country to really increase the capacity for them to take on student nurses is one of the ways to help solve for the gap. But it's still not enough to close that million new nurse gap. So what are the implications then? So what has happened is that because we haven't had enough nurses to care for patients, hospitals have actually had to close inpatient units. Patients are still coming to the hospital. And so if they can't go to an inpatient unit because I don't have enough nurses to care for those patients on the inpatient side of the house, those patients are staying in the emergency department and really overwhelming that emergency department. And in many cases across the country, we've seen hospitals having to close because they just didn't have enough nurses to care for their patients, which further amplifies and exacerbates access to care, especially in those communities where there are social determinants of health are the greatest, so both in the rural communities and also in poor economic, poor lower income areas in cities. The other piece about this is that without enough nurses, if we stretch our nurses and the nurse to patient ratio is too thin, then we see a decrease in the quality of care that's delivered and an increase in the number of hospital-acquired conditions like pressure ulcers, falls, patient falls and falls with injuries, catheter-associated UTIs and central line infections. And so there's a direct correlation between staffing and quality. And then the piece about the nursing shortage isn't just that we have higher nurse-to-patient ratios. The nurses caring for the patients in the hospitals are often new graduates. We don't have that experience and expertise. It takes about 2 years for a new nurse to really feel confident and comfortable and expert in that particular area of specialty to really know what to look for in patients. And that then translates into an increase in medication errors and higher morbidity and mortality rates. Any questions or comments about that so far? Okay, so as we've read about in the news, it's well known that in order to fill the hospital staffing needs, the nurse needs, that hospitals have turned to staffing agencies. And nurses, as many actuarials have said, hey, I can make a lot more money as a traveler nurse. So if I have my 2 years of experience, I can really I can go anywhere and work. And if I'm willing to travel, I can increase I can improve my living arrangements and my income pretty significantly by traveling. And there's a cost for hospitals then to pay for those traveling nurses. Now, the traveler nurse isn't making all of that money. The agency is making a considerable amount of money on those traveling nurses, but it's costing the hospitals a significant amount of money. The average annual cost difference between a staff nurse and a traveling nurse is over $150,000. And you multiply that by the number of nurses that you have working in a hospital, and it's unsustainable, right? So how do we manage that? And what we've seen as COVID and the pandemic is starting to wind down, that hospitals have figured out how to renegotiate travel contracts and change their recruitment and retention policies so that they're spending a little bit less on travelers, and yet it's still a challenge. So we don't see that going away. It's gotten a little bit better since this time last year, but it's still an issue that hospitals are trying to solve for. When do you want to talk about this piece?
Yes, please. Thank you, Sandy. Now, absolutely believe in the challenge that we're currently facing with the nursing challenges. And I believe nursing is the backbone of any healthcare system when it comes down to it. Now, but looking at it slightly broadly from the perspective of the concept of virtual comes through the digital piece of the puzzle. And looking at it from the whole hospital or whole healthcare system perspective, the challenges really today is coming from protecting the base, as in most hospital systems are facing the same disruptor competitors coming into the market. If you haven't heard about Amazon Care by now, it's absolutely there and taking a hold, especially with the simple motto of you can see a healthcare professional within 60 seconds or less. So they are targeting the access piece of the puzzle, but impacting the hospital system as a whole from the angle of taking away the simpler, less chronic, less complex cases away from the hospitals and the clinics, which is actually margin producing part of the puzzle when it comes down to it. And then turning around and continuing to push the complex cases to the hospitals to be able to manage and handle. And again, removing that available dollars and margin and leaving them with more complex cases. And in our particular case, nurses to take care of, again, more complex cases. So we're looking at this from a perspective of how does hospitals, healthcare professionals, and organizations limit and, as we call it, protect the base and stay ahead of the competition. It goes in the concept of, again, fighting fire with fire in the sense of using the digitally available technology and capabilities as well as AI technologies that are out there. Data and digital enablement combined can actually compete because most of the organizations and most of the professionals have brand recognition that can utilize that they can utilize against the newcomers in the market. However, if they don't utilize these technologies and capabilities in the market, those newcomers are continuing to erode away the margins away, and that's going to create even further challenges for hospital systems in the market. Sandy.
Yeah, so I think what we've learned from the pandemic and what we've seen as a result of the pandemic is this adoption of technology at a rate that we hadn't seen prior to the pandemic. And so now so there are a number of use cases where technology is enabling us to have healthcare delivered to the patient and incorporated into the workflows, and primarily in the ambulatory setting, but we also have some use cases, examples on the inpatient side of the house. So we already know we get telehealth visits with medical providers at the push of a button. There's technology and there are platforms for supporting post-acute care and rehab, particularly around physical therapy. And so before, patients would have to actually go to a physical therapy location for their post-surgery rehab. Now it can be done virtually. We'll talk a little bit more about EICUs, but EICUs incorporates technology to ensure that that high level of expertise for managing critical care patients exists in ICUs where maybe that resource doesn't exist. We have in-home remote patient monitoring, and so patients are able to actually leave the hospital sooner because they can be monitored remotely using the technology. So we're monitoring heart rate and their heart rhythm, blood pressure, other vital signs, so that it's an early warning system, and it also is a way for us to keep patients out of the hospital potentially who would be showing up in an emergency department. So really thinking about how do we optimize the care of patients across the continuum. And then we also have some virtual vendor support services. So how do we supplement the needs for really expert physicians in particular to support hospitals, particularly in smaller communities where they may not have that expertise, for example, in the neurosciences. If a hospital only has one neurologist or two neurologists and they need a vacation, how do they backfill that particular role? And so there are ways in which organizations can use technology to supplement their existing staff and provide that additional expertise and resource. And then the last piece that we're beginning to see is really hospital at home, where we can provide a lot of care, acute care, in a patient's home, and we can do lots of diagnostic studies. So we provide nursing care, medication administration, infusions. We can do diagnostic studies. We can't do a CT scan yet, but we can do x-rays and ultrasounds and those kinds of diagnostic studies, lab studies, and also consult with our provider to manage the patients at home. And so we're seeing more and more of this because, quite frankly, it's less expensive to care for patients outside of the hospital. And hospitals and healthcare systems are looking at this from a holistic perspective of how do we manage the care of an entire population of patients, because now we're further challenged with not having enough nurses to care for the patients in our hospitals. So that's a little bit about some use case situations. Let's talk a little bit more about the EICU, because this really sets the stage for how we're thinking about virtual care supporting the inpatient side of nursing care. And so in an EICU, you have what's called a hub and spoke model, and you'll have a centralized support center that is providing monitoring and support to remotely located hospitals in the spoke model. And so because we have virtual technology, in the olden days, we would actually have people sitting in a physical location at the hub, providing support to the spoke hospitals. Today, we could actually do this all remotely, and so you could have a virtual support center, a hub, for the team to support a number of hospitals across a region, a given area. And so it allows the team in the ICU actually at the spoke hospitals to connect directly with the hub support and vice versa. The EICU team can round virtually with the local ICU team to really assess those patients, provide guidance and expertise on how to manage those patients. And the ICU at the spoke hospital could reach out to the team at the support center at any time, asynchronously, to say, hey, I have a question about this patient. Can you help me with that? And the other piece about this, and Ona can talk about this, is how AI fits into this new technology. So we're getting smarter and smarter about how we can manage patients and using technology to provide that support. The other thing about an EICU is if we have a team of people working in a support area, a support team, even virtually, they can provide a whole lot of care to lots more patients than if they were to be in a facility working physically. And so in this model, you'll see that with a support model, with a hub, that hub could potentially manage up to 68 patients, and with a smaller team than if they were to disperse that model across a number of different hospitals. And so there's continuous monitoring. We're able to triage those patients for the physician to review. There are opportunities to really have alerts, identify and prioritize those alerts and share that information with the team that's in the hospital. So it's another set of eyes and ears and people, experts, looking for and managing the care of those patients to help prioritize where the spoke hospital team needs to be focusing their attention. And so it just broadens the support that we can give, and it's a more efficient use of manpower. Anything you want to comment on about that?
No, you're hitting all the highlights. I wanted to kind of speak to it from the AI and digital capabilities perspective, but I'm going to hold off till we get to those few slides right now. Okay. Unless there's any questions, I'd really love to see if there's any questions.
So, Sandy, you talk about the EICU. I mean, that's obviously the poster child for this. how do you see this as different? I mean, it's clearly different, but and forgive me if you're yeah, if you're going to start answering these questions, maybe we should hold the questions till afterwards. I'm not
Well,
sure.
let's get to the next slide, Dr. Nick. I think I know where you're headed with this. So let's look at the next slide. So this slide is a visual representation of how the virtual integrated care delivery model would work. So think about the hub and spoke model for the EICU. Now you have a hub, you have a virtually located RN who is supporting a number of care teams in a hospital. Think about this as a medical cardiac unit. So we have patients who are on telemetry, they have IV medications, and we may have some pretty inexperienced nurses managing the care of these patients in the hospital. Now we also have, as part of the care team, a virtual nurse who's located at home, who is visualizing and monitoring all of the technology that exists for that set of patients. So I might be watching the heart monitor. I'm in the medical record, reviewing the order sets, making sure that the orders are being followed, that we're actually using evidence-based order sets, that if there is a change in a patient's condition or the lab values come back abnormal or the diagnostic results are abnormal, I'm going to see that before that bedside nurse will see that information, because I'm not delivering direct patient care. I have the capacity to see all of that. So that's benefit of having somebody located virtually. So there's another set of eyes paying attention to this and getting that information to the bedside nurse in a more timely fashion and in a prioritized way. Then if we think about how the virtual care nurse could virtually integrate with the patient, we have a wall-mounted TV screen, and I could, as that virtual care nurse, I could virtually knock on the door and come into the patient's room and have a conversation with the patient. I could include their family member or the patient advocate, so that the family member knows what's going on as well. And I can have a lot of discussions with the family and the care team and the patient around what's the plan of care for you today? What's the goal for your admission? When will we know that you're safe to go home? What are all the things that need to happen in preparation for that? There are things that we have to do from a regulatory perspective in nursing around data collection. So there's a whole admission database that we have to complete. Much of that doesn't have to be conducted or performed at the bedside. It can be done with using a virtual care nurse. The bedside nurse still has to obviously physically assess the patient and document their findings and connect with the virtual care nurse to make sure everybody's on the same page. But that workload of completing the database, asking information about medications, reconciling medications and allergies, understanding what some of the social determinants of health are that could impact the discharge planning process. All of that information could be collected by that virtual care nurse and offload that administrative work from the bedside nurse so that he or she has more time to care for their patients at the bedside. The other cool thing that we find interesting about this is, now if I'm an experienced nurse, I'm an immediate resource to that inexperienced nurse who's been a nurse for 6 months and says, I'm not really sure what I should be looking for, or this is what's going on with my patient. What could that mean? Or I need to have this challenging conversation with the patient and the family, and I've never had that conversation with a patient before. How best should I do that? And so I would be available asynchronously with a little tap of the button, so I could have a conversation with that bedside nurse in the nurse's station to say, what's going on? How can I help you? So that's how we're envisioning this. There are very few organizations nationally that have done this. Some of the bigger organizations like CHI have done this out of necessity. And we're finding that other organizations are exploring this as a way to supplement the team at the bedside. So we're moving away from primary care nursing, where we had a nurse taking care of 4 patients, and maybe they had a CNA working with them, to different care team models where we have an RN who's paired with a CNA an LPN, and maybe a virtual care nurse now caring for a team of 8 patients, so that the nurse at the bedside feels very supported, because now they have that expert nurse. They have someone who's really looking at all of the information that's coming in and synthesizes that on their behalf, so that they have the right information at the right time to make the best decisions for their patient. So this is really the crux of virtual care delivery on an inpatient unit, is how we're thinking about it. And there are other ways to bring the rest of the team members in. There's no reason we couldn't also have a care manager working virtually, a hospitalist working virtually, and supporting the team at the bedside. Joe, Dr. Bernal, you have a comment?
Yeah, I do. I'm just struck. First off, this is fantastic, Sandy. It's exciting, reassuring, and it's clear to all doctors that doctors make diagnoses and prescribe treatments. Nurses actually care for the patient and the family, and take either the lion's share or all of the education. I'm a disciple of Virginia Saba. I deeply understand and appreciate nursing. And I think what really struck me is Dr. Nick had me watch, I mentioned this before the conference started, the HIMSS session on crew resource management and Top Gun. And what they showed was that when you separate tasks the way you're describing with the virtual and the nurse at the bedside, it becomes possible to create a reliable environment where the individuals involved are less likely to get saturated, and also have clarity on who's responsible for what that can actually be fielded. So there's the legacy part of me who enjoyed being at the bedside and being able to round frequently, et cetera. I feel a sense of loss around that, but I'm curious whether there are other elements of crew resource management that you may not have spoken to yet that come to mind, given that that's how I'm taking this. Sandy?
I do think the whole concept of crew resource management is spot on. And I think this is still a novel approach to patient care delivery. And it's incumbent upon us to define roles and responsibilities so that we're designing workflows that are consistent and reliable, and understanding who is responsible for what aspects. So that there's role clarity, which is part of that whole crew resource management. And then how do you escalate things as you would if things aren't working the way they should? And so that's part of our role as we help organizations design and implement this to make sure that it's safe for the patient and quite frankly for our caregivers who are feeling that moral distress when they leave the day because they don't feel like they have the bandwidth to care for the patients the way they need to or want to, and they don't have the expertise to really feel confident that they're making the right assessments and the right decisions by themselves.
I think, I was going to make the point that there's some tremendous opportunity for micro CME as part of this. But, to build on the point you're making about this, imagine having a senior colleague that's sympathetic, but, not in the moment and sort of wrapped up in all of the busyness that you tend to have, but sort of watching over your shoulder to support. I think that's actually another positive around this that gives you just another method of helping dissipate some of this awful burnout that I know, our colleagues are feeling.
Dr. Nick, the other thing we're exploring and what we're excited about with this is that we lost a lot of experienced nurses, right, as part of the pandemic. They retired. They said, "I can't deal with the stress. I don't need to. I'm done." And a lot of them didn't really want to leave, but they felt like they were putting themselves at risk and their families at risk. This is a great way to retain those experienced nurses, to be able to serve as that virtual nurse. And maybe there's a blended model where they work a little bit at the bedside and they work a little bit virtually, so that they don't lose touch with the there's a lot to be said for being a bedside nurse. There are days when I miss it. I got so much joy. I got so much joy out of seeing patients improve and get better and really connecting with them. And so I think there are opportunities for us to design this in a way that works well for that particular organization and their culture. But I think from a retention perspective, it's huge. So if you want to go to the next slide, this is where we get into some of the other use cases for our virtually integrated team, because we have virtual nurses, but we think that there are ways to engage others to create that virtual hub of experts who can provide the support that some of our teams need at a more optimized cost ratio, if you will. And so all of the things on the left are things that a virtual care nurse could do to offload that administrative task for that bedside nurse, who then can really have the information he or she needs that's most important. It's already been filtered out, and now I can react and respond to that prioritized information, which makes my job as that bedside nurse more effective. And I feel more confident because I have a team behind me that's advising me and synthesizing all of the pieces of data coming in so that I'm less likely to make a mistake, and I'm focused on the right information. So the virtual care nurse isn't taking my job away. They're helping me do my job better. And likewise, if we think about the hospitalists, the hospitalists and many of the organizations we work at are pretty green. They don't have a lot of experience. And so is there a way for us to support the hospitalists? And can we do integrated, interdisciplinary, multidisciplinary rounds, daily rounds, and do them virtually? And how do we do that so that everybody on the care team knows what the plan of care is for their patients? And just be smarter about how we're managing the care of that patient, ensuring that we're following best practice alerts that pop up in our EMR these days. And if we're not, why aren't we? And so there are so many things that we think are valuable in this work to really improve patient care, improve patient safety, and improve patient outcomes. That's why we're really passionate about this. Owner, you want to talk about this in AI?
Yes, I want to jump right in. And I won't necessarily go every single line item on this slide, but happy to answer any questions. Most of the examples on this slide come from my personal experience that I've been fortunate to have participated in. But as Sandy was talking about the operational model of the virtual care team, I want to take us a step further from the standpoint of we are going to introduce complexity and change to the organization. So to reduce the anxiety and the complexity, we should absolutely take advantage of already proven use cases of utilizing artificial intelligence and computer algorithms that are serving in healthcare space in a similar capacity already. From examples of remote patient monitoring and interventions in general, when minutes count, like in septicemia and AFib cases, we have created models in my experience with our artificial intelligence teams that continuously real-time monitor the patient's vitals and everything that's going on. And as we talk about rounding and even including virtual rounding, we still have gaps of coverage of eyes on the patient at times. This is when the computers can come in, help and support both the experienced hub nurse as well as the bedside nurses, and continuously provide every second of the day sort of coverage that can identify and recognize these patterns Some of the examples on the outer side of the slides that you will see, you can detect neonatal challenges up to 24 hours earlier, analyze remotely the data that's flowing through the system for identifying the patient coding and or crashing opportunities, wouldn't be the best word to use, but challenges that come around before the nurse, the physician, and or the virtual team actually gets to that patient. In same cases, the ability and the technology that's currently available to us that we can actually analyze and stream data in terabytes, which is so much more amounts of data from the first days when I started doing this work 20 some years ago. And in addition to that, as we mature in this space, we can then introduce more unstructured data, meaning as the patients leave the hospital and the bedside, they are being monitored with whether it's a wearable device or home hospital kits that detect through speech, through body movement, and through other pieces of the puzzle that can be then connected with the patient's record to show a full picture of, yep, the patient's actually improving, or nope, they're either stable or actually deteriorating, or whatever the case may be, are all currently being done in separate pieces or individual use cases or use case basis, if you would. The idea of combining several of these to enable the virtual team to be able to provide a broader range of coverage and capability is what really excites me about what AI can do in this space. And I'm really excited about actually having done some of this, but also wanting to put this together and provide a full picture of this and do this outside of just a simple use case basis. Going into the next slide, in addition to the supporting the role of AI, it also really is looking to address the quadruple aim that, again, most hospital systems and healthcare organizations are challenged with. Again, as Sandy mentioned, we have patient events, safety events, hospital-acquired conditions. AI can provide the coverage that it can in the cases where we know that there's a patient fall risk, and identify even virtual assistant that identifies the risk of the patient's fall ratio at that given moment, and address the issue, whether by utilizing a virtual sitter or utilizing the alerting mechanism to say, hey, this patient is getting out of bed. Why don't we just send somebody in to address that from a clinical outcomes perspective? Same case for shortening the ED length of stay for admitted patients, length of stay in general, decreasing overall labor cost of, again, as Sandy highlighted, several of the current challenges of both the travel nurse costs, but also the unsustainable model that we're in right now through the pandemic. We can definitely improve such cases. And in the same token, again, allowing more transparency and allowing more timely information sharing improves the patient and family experience. And then improved outcomes absolutely turn into patient satisfaction. And on the professional satisfaction side of the story, as we're highlighting the burnout rates and the challenges that continue to face our clinical staff. And if we can do anything to take the load off their shoulders to make their life just a tiny bit easier, which there are proven cases that we can with AI, we can address all four of those quadruple aim challenges. We're kind of going to the side of, okay, well, now what? Why do we, or how do we do this? Many organizations are on one part of this digital journey that we've created. So digital and analytic capabilities add value to the organization. Now, again, everybody's at a different step of the way. And sometimes people kind of bounce around, don't necessarily start on the first step. But however, that also creates its own challenges. Maybe you may have heard the term of shiny object syndrome. People see a really cool technology and or capability, purchase that technology, and then implement it in their hospital, but they either don't have the professional skill set that comes along with that, or the additional technological support mechanism and infrastructure that needs to be in place to be able to do so. So we normally look at it from the angle of, you have to call it baby steps or not, you have to have your essentials and enablement levels, which is your foundational table stake sort of capabilities in place, which then will enable you from the angle of get to an operational executable state. And then from there, go into more advanced, explore the next advanced capability in the healthcare market perspective, and ultimately turn all this into both a patient and provider and clinician experience when it helps as a full circle at the end of the puzzle. We have some additional use cases here. And by the way, let me take a pause. I get excited about this and just kind of go 100 miles an hour. Any questions or comments? And if not, I'm happy to do answer at the end as well. Okay, use cases we highlighted. So as I mentioned on previous slides, a lot of the examples were from my past experiences. These are publicly available. All three of the organizations you see on this page were highlighted on CMS as doing one form of virtual nursing or shape or form of virtual nursing and or digital care team studies, if you would. The most common result that's so far available is that the teams are working a lot more coherently. The burnout rates are definitely being addressed based on the results coming out of it, and the employee morale that's related with burnout and coordination is definitely having a positive impact from a perspective of putting these teams in an organized setting, assigning specific tasks. Everybody knows that somebody's got their back and this work is being done in a team setting perspective. So taking some of that pressure off the clinical team's shoulders and yielding results. So those are the available case studies. In addition to that, we utilized some of my past experiences, health monitoring and intervention in actual healthcare setting examples. These are, again, three mostly internationally recognized organizations that can absolutely have direct impact of utilizing AI and advanced analytic or real-time analytic capabilities in their clinical setting today. I'm going to take a pause again. Any questions or comments?
I have a question. I would think that you wonder with something like this, how do the patients receive it, and how do the nurses and the caregivers that are either the recipients or the beneficiaries or the victims of all this receive it? I would think they would love it, but what's the real world experience, or do you have that yet?
Yeah, Jim's. Oh, I'm sorry, Sandy. Go ahead.
That's a great question. So a lot of it is on the nursing side. It's about engaging the team at the very beginning around how this is going to help them in their jobs, and then engage them in the design and implementation of the new processes. On the patient side, it's really teaching the staff how to have the conversation with the patients and the patient's family members, so that the family and the patient understand around our respect for their privacy, and how this virtual care nurse will interface with them, and how it will benefit the entire group of stakeholders. And so it's really about how do we message that to the team and to the patients and their family.
Do you have any kind of, this may not make sense, but do you have any kind of opt-in, opt-out capability that a patient might have?
Yeah, the patient will always have the option to opt out if they don't want to have the virtual nurse be part of their care team. And always there's the option if I'm the virtual care nurse working remotely and I virtually knock on that patient's door to come in and it's not a good time for them, they just decline the invitation.
Oh, okay.
Jim, two examples that I have from my own personal story, if you would. One, we have developed a virtual rounding capability with our AI function at Ochsner Health System, and the results and the responses from the clinical team, both nurses and clinicians were alike. That made their lives a lot easier. Again, it takes up to 3 hours sometimes to go around a big facility to round. And by the time you leave that patient for the next 2 hours and 59 minutes, you don't necessarily have a lot of exposure. So the results were very positive, alerting at the right time, small tweaks, but the response from nursing staff as well as the clinicians were this was just making their lives easier. And on a non-inpatient setting, from a more of an oncology side of the story, we have created clinical trial matching for oncology patients, which normally staff nurses have to go through hundreds of charts and review them, which takes them a significant amount of time, and it can take up to 30, 45 days before they can address and match the patient to a clinical trial. And by then it may be too late because they may have already started on their side. So long story short, the reduction was up to 70% of that time for recognizing and finding the right match to the right patient or right patient to the right clinical trial. Again, the results were well received from the staff nurses' perspective.
Okay. Thank you.
And Owner, we have another question around from Dr. Barmel. Can you speak to when AI or machine learning migrates well to the next hospital and when it doesn't?
I'm sorry, I didn't catch the last part of it. I'm reading it right now.
Okay.
Dr. Bormel, could you help me with the next hospital piece so I answer the question correctly?
Sure. Yeah. It's at HIMSS, I guess last month, Ryan Vega, who's the head of innovation for the VA, and that's the current organization I work for, was talking about, there's certainly AI and ML, machine learning, have been used for diagnosis, classification, and proposing treatments for things like COVID, and just been really, really quite remarkable. And he gave an example of using machine learning to look at chest x-rays of patients to determine whether they have COVID or not. And at one hospital in New York City, they were getting like 87% concordance between what the AI was saying and what they ultimately had. It was just really phenomenal. They took the same algorithm with the same training across the street, and the performance fell to 56%. So basically a coin flip, failed to have the integration. They went and did a statistical analysis of it, and they found that it was the age of the radiology tech who did the chest x-rays that ended up having the explanatory power. And it was, which is, not obvious that there would be so much variation driven by the tech unless you have experience in a clinical setting, in which case you go, yeah, and the clinical tech is also correlated to whether they're using the better or the not as good technology and using more portables and what settings they tend to go into and what they're qualified to go into. So it's really complicated. But there is kind of an expectation when you see great results from AI and ML that for the hospitals, and you gave some great case studies there, when you take it to the next organization, in some cases, people are really surprised that the AI and ML doesn't hold up. And I'm just wondering if you sort of have some thoughts and insights, because clearly with things like IBM Watson, they completely oversold
Right.
the the power of technology, and in ways that those of us like Suniti and I and Jim and others, were talking about 10 years ago. So I'm just wondering how you think about AI and ML.
Absolutely. And you actually just kind of gave away the answer in there a little bit. Thank you. I appreciate that. So machine learning, or AI in general, or specifically the use case of interpreting images, comes from the concept called supervised learning. Supervised learning, in simplified terms, is utilizing human input to determine how something is measured. So in this case, it's a chest X-ray. The X-ray is measured based on the human input, which is the radiologist and the technician involved. So the geek in me, the quick response is that the computer makes less mistakes. However, humans tend to make more mistakes. That being said, though, that's why the variability is coming from when it's involving two different folks with different skill sets and interpreting the X-ray or the whatever the image may be. That's one part of the puzzle. And on the second side of it, as we highlighted, that foundational layer of essentials and the foundational first two steps of the digital journey really involves building the right level and right type of organization, meaning you have to have data scientists who are savvy in healthcare space. So there are a lot of data scientists out there. I've experienced this myself. They have great knowledge in financial industry, and they can actually predict when the stocks are going to go up and down, but they can't necessarily interpret that into reading images. Now, they can absolutely learn that skill, but having the right skill set to be able to then have that conversation, for example, and recognize the differences or the subtleties between Tech 1 and Tech 2 in how they were even interpreting that image makes a big impact on the results that you can receive. We experienced that in a similar fashion at Ochsner when we first started trying to build our models around alerting and what patients would code. Again, we were collecting information from our clinical care teams, and there was a huge level of variability. The teams that we had a lot more technical savvy had understanding to be able to explain it to the technical teams to be able to interpret and then turn it into usable functionality. So there's a lot of nuances in there, but it starts with building the right team and utilizing the right skill sets.
We have a couple of questions. Leo Scanlon and Barry Lipsy. Leo, do you want to go first?
Thank you. Yeah, a little cautionary tale on the point that Joe just raised. Ben Gurion University, about a year and a half or 2 years ago, demonstrated a quite startling capability of machine learning attacks on images, reading images that basically fooled a vast majority of the analysts who are looking at the outcomes of CAT scans and so on. So this is another problem that's standing out there just to be thought about. But my question is this. The recent news about the not too surprising failure of the DoD's implementation of a proprietary EHR system out in the state of Washington raises the question once again of when will this problem of interoperability become a major impediment to the adoption of and implementation of telehealth capabilities, or does telehealth open up the opportunity for end run around these incumbent Goliaths? And if you give me a sense of what you think that problem space is, appreciate that. Thank you.
Sure. Thanks, Leo. Really well thought out question. So I have, I'm going to answer this in two parts, one with my heart and one with my head, if you would. My heart response to this immediately goes to countries like Australia. I'm not necessarily for big government, but government did the right thing in Australia and said, no longer will we have interoperability problems because the big players won't play nice, and said one EMR go across the board. So that's one way of solving it. And there are amazing results coming out of that one. Now, free market competition, all that good stuff is kind of thrown out the window in that case. So that's one part of the story. The second part is the world that we live in, which is North America, U.S. based market, is inducive to these big players like Epics and Cerners and Athena Healths and all the other ones in the marketplace. They're incentivized to not play nice with each other. Even though everybody talks about interoperability, I've been in the bowels of all of these organizations and systems, and my life has been around data, trying to connect the data from an interoperability perspective. They do not play nice with each other. So the quick solution, I think, to your point, comes from the disruptors that are coming from the left field, like Amazons, like Googles of the world. At one point or another, they are going to get over the hump of needing to capture the data out of the EMR. And I don't know when that breaking point will be, but it will be from a perspective of, as they capture the patients outside of the traditional hospital setting, like Amazon Care or whatever you want to call it, they are going to have to get that additional data from the native organizations, because now they're actually caring for the patient. So they're going to start breaking those walls down. And the other piece is they have enough money to throw at it to outlast the current challenges of the big EMRs, usually basically dragging their feet and outlasting all of the organizations who's tried to solve that problem before.
Can I ask you to stop sharing the slide deck, please?
Sure.
Thanks. And maybe I want to add a bit of color to that. I want to be on your positive world of we'll win this out, but I'll cast your mind back to two big companies that stepped into the healthcare sharing space with, let me think, was it Microsoft Health Vault and Google, whatever, forget what they called it, stepped away again, now they step back. I don't know that Deep Pocket solves that problem. I mean, I'd love to be disproven. I'm a little bit more skeptical.
I think it's not the money, it's more that they actually have the money to outlast it. All small organizations have always just kind of fizzled out because they couldn't outlast the Epics and the Cerners. Just again, probably my optimist for a Friday, usually a pessimist, but we'll leave it at that.
I'm sorry, I know there was somebody else that was in line for it and I jumped in. It's Barry. I apologize, Barry.
That's okay, Nick. This actually, I want to go back to the question that Joe raised and Anthony, you addressed. Joe, you were saying the machine learning AI worked really well in one hospital and across the street it didn't, and it was the issue of the techs and the training and their perspective. And one hospital it worked 80% or whatever it was, and the other, it was a coin toss. I'm kind of curious, this seems to lay it on the feet of the problem of the AI and machine learning. Is it really that, or was there just a large case of misdiagnosis even without the AI and machine learning? And did this actually bring to light a problem that has nothing to do with technology, everything to do with the training? And you talked at Ochsner, and team one did really well, and a different team had more challenges. Is this a technology issue, or is this a training issue? Because it's the way you were talking about it, sounds like we were positioning it as a tech issue, but I'm not sure it really is from the way it's all being discussed. You're smiling, Joe.
Yeah, so sorry, I had to unmute. Many of you who are, first-time caller, long-time listeners to Health TechNet, or long-time participants, know that I lost my best friend to pancreatic cancer a few years back. And Anthony, for me, the audacity of the IBM Watson folks claiming that we could kill cancer with data. That's a quote, right? And that that we could find new cures using the power of computers, which include the AI ML stuff. And also, just as a quick aside, failing to recognize that that the power that they had, as demonstrated through Jeopardy, was to reason over real data when they really had it in under 3 seconds, in something that would take a human to do 2 hours to do, so that when you have data, you can actually surface it. That's they didn't go there, and that was their distinctive competency. So it's that audacity that bothers me. So if I were asked the question, when will AI go from one hospital to another, and when will it not? I think this, one issue that it seems like the people, Ryan Vega, who brought the story to light, says you really have to test AI in the next hospital with their own data and watch it, on a daily or weekly basis, because things change. The nature of the COVID patients that present, the nature of the variants, Omicron, today, and whatever the next one, and let's pray that there isn't, or it gets milder as you would expect it to do. So I think there's the AI and ML is absolutely critical. I think that Barry's has it absolutely right that there are cases where human performance, or the decidability given available data, independent of whether you use humans or not, in many cases our science isn't good enough, isn't sensitive enough to make some of these decisions. But I do think that there are cases where we're just not using the technology at all, and should be. So, for example, one of the things that Nick and a variety of other physicians who I'm following closely are doing, they're using things like these Aura rings. I don't have one, so I can't do that. But things like using AI to look at variation in heart rate, and seeing whether or not that's correlated with something. That's data we haven't had before, we haven't analyzed over. So I'm excited that there are opportunities to use data with AI and ML, and that this is really, really critical to be done. And we need to also be careful so that when we have failures, we don't throw the baby out with the bathwater and say that it couldn't work. And last thing, and then I'm going to mute and be silent. I worked for Cerner for 6 years. I am in violent agreement with your statement that the big players know that they can outlast the either the smaller vendors or the political regime that is attacking them today, and that's kind of how it's worked in this battle of devils and gods, where each of us on this call can and maybe have been in both camps at some point, while trying to do the right thing, and with good conscience. I do think that that the battle is, the way I currently see it, is between open standards and the proprietary solutions, and the economics of that, to your point, are not impressive on either side of the equation. So I am in agreement with you. That's my closing point.
No, all well said. And Barry, I also fundamentally agree with you, because maybe let me make this statement first. I don't consider any technology to be a replacement of human skill at this day and age. Maybe we'll reach that old Terminator joke of Skynet will be created one day and they'll replace humans. But till we get there, I consider all of AI and other capabilities, advanced technologies today, to be an enabling function. So if we use it as such, we'll benefit from it. But if we, and to Joe's point, in IBM's case, they oversold it in the sense that they were all in it to grab market share and make this profitable when it comes down to it, so that they were going into it with we are replacing the human brain or the human mind to make decisions, or whatever the case may be. The reality of it is, this needs to be more like an exoskeletal gear that you put on. So instead of only being able to lift 50 pounds, now you can lift 200 pounds. So that's the idea of using AI and technology. Thanks, Joe. That's the concept that we really need to be focusing on, in my humble opinion. When it comes down to it, I wouldn't, even me personally, and being a technology geek and been an analytics experts for the last 20 years or so, I would want a real human clinician taking care of me rather than a computer taking care of me today.
That's exactly right. This is not a replacement to the experts of someone who's actually laying hands and eyes on the patient, and it's augmenting the information that we have at our fingertips to identify changes, minute changes in patients' conditions earlier, so that we can intervene earlier. But it's not a replacement for clinicians.
And this human. Oh, I'm sorry. Go ahead, Richard.
Hi, Sandy. This is Dr. Richard Singerman. I'm at Day-to-Day Health, which is now part of Babylon Health. And so my focus, I'm one of the heads of research there. And I'm really focused on, I'd like to drill down a little bit more into a couple of your use cases. And in particular, right at the cusp between hospital discharge and hospital at home, because what we're hearing from some of the hospitals that we work with is that they have the clinician capacity to take more cases in at the front end, but their patients are pretty ill, and so they can't send them home. And even if there was technology in the home, there's not someone, a person, a trained nurse or someone, even a medical assistant, that could be with them in that home at 24/7 to allow for a safe environment for that discharge. And so I'm wondering, and it's a big revenue loss opportunity, and quite frankly, no one wants to stay in a hospital any longer than they have to. So I'm wondering if you've kind of gotten into it. It's kind of like almost like the touch point between your discharge use case and your hospital at home use case. I wonder if you could talk on that for a minute.
Absolutely. So, go ahead.
So I guess the comment I have there is I'm with you. I think that the hospital home is a great idea, but I think we are transferring the burden of patient care to families when we say you can deliver acute care in the home setting, and our family members aren't equipped to do that. So I'm treading lightly in the hospital home. There are parts of it I think that could work really well and keep patients out of an emergency department theoretically. But I'm still a skeptic when it comes to really delivering acute care in a home setting because of the things you pointed out. I just think that my family's not prepared to care for a family member at home, even if a nurse visited twice or three times a day. We have to teach that the burden is now shifted to the family. And I think from a cost saving perspective, Medicare likes this arrangement, right? Because now we're not paying for hospital care, but we're also transferring that burden to the family members. And I don't think we've really explored that sufficiently.
Yeah, and I'm kind of just running with that a little bit more. I mean, it's almost like the virtual ICU, but in this time you have the medical assistant, perhaps, if there's not enough nurses, who could be in the home, and can the technology and the processes then support the medical assistant to make a quote unquote safe hospital at the home?
Yeah, I'm not confident that we can. I don't think that. I've worked with lots of medical assistants, and they don't have the same education and knowledge base or critical thinking skills, and they can't be a substitute for a professional registered nurse with, more than 30 years of experience and right. So I think that's part of it, and there, quite frankly, we don't have enough of the unlicensed assistive personnel in the pipeline either. And so our jobs as healthcare administrators is to develop the pipeline so that we get unlicensed assistive personnel into the pipeline and then promote their education and professional growth so they become licensed professionals, whether it's PT or imaging or nursing, wherever we need them. But I worry about the hospital at home. I don't think we've fully explored how best to take care of those patients at home.
So I don't disagree with you, Sandy. I would just say counterpoint to that. We've already shifted that care. We've dumped it on those people anyway. And part of me says that if at least we could give some technical support is not quite the right term, but it's the comfort feeling of we're overseeing this in a way that says if things are going south, we're going to know that before you ever would. I think that ship has already sailed, unfortunately, but you're entirely right. There is the skill set isn't there.
And I don't think we have long-term, we don't have any long-term studies, data to support whether there are positive outcomes or not. And the burden on the family is significant. And Joe, your comment, you're absolutely right. Been there, done that, have the t-shirt.
And the problem, I think, running with that volume one more is that, you know, let's say someone gets discharged to rehab, which if I remember when I was doing this for my parents many years ago, they paid like, that's what, paid like 90 days. And so on day 91, your parents are magically well enough to be home.
Yep, a lot of this is being driven by Medicare, right? CMS to drive down the cost because we have an aging population that continues to grow in size, and our healthcare demands are increasing as well, and we can't afford to care for everybody in the hospital. Great discussion. Thank you.
We're coming up on time-ish. I just want to make sure that we are conscious of that. We can continue the conversation, absolutely, but from a formal standpoint, I want to thank my two colleagues and friends for putting together a great program, for thinking this out, you know, pushing the envelope in a way that is different and I think extraordinarily important in this day and age. So much appreciated, and certainly to everybody for the interactions and discussions. Before I close off, any closing comments from David or Jim?
I will make a general comment, and that's that a piece of this discussion sort of previews something we're going to use to kick off the discussion in May, and that is, why is healthcare so different? And why can't we easily transfer technologies and expertise from communications, from wherever, into healthcare? And we've, Joe and I have already been chewing on that a bit. I've beat that drum for years, but when Joe was talking about Microsoft and Amazon as being examples of companies outside of healthcare that have sort of come in and then exited, I actually keep a list of companies that have entered healthcare and then exited, sometimes tens, sometimes hundreds of millions of dollars poorer. And we'll be talking about that next month. So that's a topic that's been of great interest to me.
All right. Well, just in case everybody wondered whether I was really in black and white or not, somebody did make a comment separately. So I'm not. It's all designed. It's part of the branding so that the ECG really stands out. So. All right. Well, listen, I'm going to close and stop the recording. Finish by thanking Sandy and Ona for excellent
Absolutely.
presentation.